This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. Let's get started with some basic definitions. We define an acute coronary syndrome as suspicion or confirmation of acute myocardial ischemia or infarction. There are several types of acute coronary syndrome. Unstable angina, where there has been a change in the pattern of previously stable angina. An acute non-ST elevation myocardial infarction, or an NSTEMI. This includes patients who previously would have been classified as unstable angina, but now we're detecting a small troponin leak because of the very highly sensitive troponin assay. And the third syndrome is acute ST elevation myocardial infarction, or STEMI. This is a true medical emergency and needs immediate action. Pathology of acute coronary syndrome involves plaque rupture, platelet activation, and coronary thrombosis, as I will show. This cartoon shows a cross-section of the wall of a coronary artery affected by typical atheromatous atherosclerotic changes. Note the large lipid core in the middle of the lesion. There is infiltration of foam cells and smooth muscle cells. This leads to a thickening of the fibrous capsule that has developed as a consequence of the atheromatous vascular damage. As the disease reaches a critical point, there is platelet aggregation and thrombus formation. This is followed by thinning of the fibrous capsule and ultimately rupture of the capsule, which spills the detritus, or the luminal contents of the rupture that's really just waste material, into the vessel lumen. These released materials add to the local inflammatory burden and can accelerate thrombus formation and ultimately coronary artery occlusion. There's a continuum of risk from acute coronary syndrome. Starting at the low end, where patients come in with atypical or non-cardiac related chest pain, their EKG is normal, troponins are normal, and they're considered very low risk and may not warrant further evaluation. Patients with stable angina are also considered low risk. They'll have stable chest pain, typically with exertion. EKGs will have nonspecific changes which were unchanged from prior EKGs, and their troponins are normal. Unstable angina, as I mentioned, is a change in the pattern of previous angina. That change can be more intense, more frequent, with a lower level of activity, or a different quality, such as new radiation to the left arm. EKGs are still abnormal, but they might be nonspecific and changed from prior EKGs. Troponins are still normal by definition, only because if the troponins were elevated, we'd be moving into the next category. And the risk is significantly higher when there has been a change of your angina pattern and you are classified as unstable angina. These patients generally require immediate medical attention, most of the time hospitalized, and frequently therapy is immediately instituted. A non-ST elevation MI is a medical emergency. Patients are having rest pain. They show EKG changes and at least a small and sometimes moderate elevation of troponin with a high risk. And finally, a ST elevation MI is typically associated with worsened pain, sometimes intractable, marked EKG changes, and moderately to quite elevated troponin leak, and are considered very high risk, requiring emergency interventions. As I mentioned earlier, there are three areas of concern to look for in a patient suspected of having an acute coronary syndrome. Ischemia is manifested by ST depressions, which are over here. The ST segment is after the QRS but before the T wave. It's depressed. and T-wave inversions in leads that should be upright, which are most of the leads except for perhaps lead R is usually upside down. Injury is associated with ST elevations. Again, the ST segment is not isoelectric. Here's the baseline down here. It's elevated, in this case, by about 3 millimeters. And infarction is Q waves that have developed. A Q wave is the absence of electrical activity towards the lead where you would have an R wave. So you have just the opposite direction Q wave showing a kind of electrical hole, meaning over leads 2, 3, and F, there's no initial electrical forces towards the lead because of the infarct. So when we see these Q waves, we know there's an infarct likely. However, the age is not determined. If Q waves are associated with dynamic changes, in this case ST elevations, this would be considered a active evolving inferior wall because it's leads 2, 3, and F infarct. So we'll see Q waves in most leads. The only exception is in V1, which is posterior. The equivalent of a Q wave is actually an R wave. So a large R wave in lead V1 is actually the same concept as a Q wave in other leads. And we'll look at a large R wave as evidence of a posterior wall myocardial infarction. So we can localize an infarct based on the distribution of these changes. If we see evolving changes in 2, 3, and F, that's in the area of the inferior wall. 1 and L is the lateral wall. V1 through V4, V1, V2 is septum. V1 through V4 is the septum plus anterior or the anteroseptal leads. V3 to V6 is anterolateral. And all of the precordial leads involved, V1 to V6, are diffuse anterior and may suggest a major problem such as an LAD occlusion or even a left main occlusion. If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.